A continuación, nos acompaña la doctora Claudia Saad Magalhães. La doctora es profesora de reumatología pediátrica de la Facultad de Medicina de Botucatu en la Universidad del Estado de Sao Paulo en Brasil. Nos acompaña acá de manera presencial con la conferencia Tratamiento de las miopatías inflamatorias y idiopáticas juveniles, ¿qué hay de nuevo? Muchas gracias, doctora, y bienvenida.
Good afternoon, everyone. Thank you, Angela, for the nice introduction. I first like to say that I'm very happy to be here with you on behalf of Joanna, the sweet Joanna that made all the efforts for bringing me here. It's very nice to be with an interesting group I met for a long time. And the topic about juvenile myositis and JDM is the main. It's also very dear to me. First of all, I have no disclosures, and we'll speak slowly in English, and I hope to make it easier for the translators. And although I can understand you perfectly for the questions, I'm not able to reply you in Spanish, only Portuguese or Portuñol. So the inflammatory myopathies are the phenotypes were beautifully described by the preceding conferences. And you have different phenotypes. And as stressed by all of the previous lectures, the JDM is the main phenotype in pediatrics in all age groups. And the other phenotypes, especially polymyositis and overlap syndromes, we treat exactly like our adult colleagues because you have less experience with this presentation. It's the same for the phenotype. I must say that the autoantibodies and myocyte-specific antibodies will be certainly a very useful tool in the future, but for our current practice, it's difficult to classify by autoantibodies. So we cannot afford, I don't know your reality, but we cannot afford this in practice. So you have to trust very much in the clinical phenotypes. That was beautifully presented. We'll summarize the muscle involvement, the skin involvement and its complications like calcinosis, and the systemic involvement. And you have this in mind to treat the patient. Because sometimes you have the muscle disease and the muscle weakness in the first 6 months of disease, and later on it goes away, and the skin manifestation, they remain for a long time. That is the reality, and the initial presentation with severe muscle weakness, edema, and calcinosis is indeed a very biomarker of what we have to expect ahead. So despite these advances in treatment I will speak you about, JDM still progresses with significant morbidity. It's a very severe disease. So to summarize the treatment, you have this picture, and you have to have this in mind. It's done all over the world. The central part of the treatment is start glucocorticoids in high dose of glucocorticoids. And the principles of the overall treatment is the choosing the correct doses of glucocorticoid. So we, as clinicians, we have to be very smart to choose the dose for each manifestation. And also, you have to anticipate the progress of treatment by adding other agents like DMARDs or biologics. So the secret and the recipe is to adjust the escalation of treatment. So use very often the pulse of methylprednisolone, monthly pulse, and there are different protocols for JDM, like weekly pulses. And sometimes along the treatment, it's very difficult to preview or to predict which patients we could wean off steroids. So sometimes we have flare, or the patient reactivates all the manifestations during the treatment with high-dose steroids. So if the patient flares under daily steroids, we have to adjust the pulse. And if the patient flares off steroids when you have already quit steroids, you have to resume it. So this is a reality I think all of you must face. But the second part is adding new agents, as I stressed. So for a big step in developing new treatments for JDM, it was the development of the outcome measures, the composite outcome measures. It was already mentioned by my colleagues, the muscle strengths, the functional assessment, the overall assessment of disease activity by the physician or visual analog scale. And there are also tools for extramuscular assessment. All these measures altogether, they make our systematic quantitative view of the treatment. And it's very useful if you can do this in practice in clinic. It's the same tool that we use for clinical trials to decide which treatment is best. We can do it in practice. So this is an example of a pivotal trial. It's called a Printo trial because until recently we didn't have the proof of concept that glucocorticoids compared to adding cyclosporin or methotrexate. The methotrexate was the first of the DMARDs that was used in practice, and many of you know that it will be difficult to conduct a trial with only glucocorticoids. And although it has a long practice, it haven't been tested so far. In this trial, it was very difficult to recruit patients because, as you know, this is a rare disease. And the other fact of this trial, you have to look at the scheme of and the protocol of high-dose glucocorticoids in the first 3 to 6 months. As you can see here in this protocol, the weaning off steroids, it started with 3 months' time. So it's a tight protocol, and that's what is desirable in practice because sometimes these patients, they receive higher doses of glucocorticoids, especially oral. So the scheme of switching to pulse or doing the pulse combined to prednisone, it's a scheme to spare some glucocorticoids and to avoid the damage of more morbidity. So this trial proved that adding cyclosporin or adding methotrexate, since the first day of the disease, it's really superior to the prednisone only. So although late, still using these DMARDs, sometimes we have patients that improve muscle strength, but they keep with skin predominant disease. So in these 2 papers, as you know, the CARA North American group is studying JDM patients with predominant skin disease. And they have stressed the main clues for reaching these patients. It's something like it's known before as amyopathic dermatomyositis, but we know they have muscle disease, but they have more skin disease. And the chronicity of skin disease, it's the most trouble. And about skin disease, you have to speak about another DMARD that is being used for a long time, and this is hydroxychloroquine. Hydroxychloroquine was used as adjunctive treatment And we, as pediatricians, we use it, as you can see in this picture of the hands of a patient with the cotrons. You can see it's pigmented. So this is a sign of hydroxychloroquine. We use it, but more recently, the dermatologists, they described skin reaction or some adverse event of hydroxychloroquine. It's very frequent in adults. I don't know of your practice, but we may discuss this. We use adjunctive because in our countries, the sunlight and the photosensitivity is very important. So besides using hydroxychloroquine and skin protection, we haven't seen so far, but in case you have rash and worsening of the rash, it's important to think about these reactions. So these reactions were stressed by an old literature, but in more recent literature from the dermatologists. The other adjunctive treatment that has been used for a long time and that recently there is a trial, it's intravenous immunoglobulin. This randomized trial, one by one, head by head, recruited young adults until old age. And it was conducted at double blind, 2 grams per kilo, every 4 weeks for 16 weeks with an open label extension. And as you can see from the graph, there is a difference, a remarkable difference of this adjunctive treatment. We have to stress the adverse events, those adverse events that we commonly see with intravenous immunoglobulin, headaches, pyrexia, nausea, and even thromboembolism were present because of the age range. But in our hands, we use very often, it's the most used adjunctive treatment in skin or persistent skin disease in JDM. We see headaches or some nausea or transient effects. It depends of the type of immunoglobulin or depends on the production. But you use it safely, and although this trial is for an adult, it's now proved with good quality evidence. And the next is the B-cell blocker, the rituximab. This trial, it's another pivotal trial that was conducted and combined in adults and children with 75 adults with polymyositis, 75 with dermatomyositis, and 48 JDM. And they use the same definition of improvement of the printed trial, but it was conducted by the adults, and so the core set of outcome measures was the IMAX core set. They use different tools, but it's the same. The difference was stressed, so it has proved a good option. But in this trial, they used rituximab for those patients who were resistant, so chronic disease or not responsive to standard treatment. So there are recent recommendations based in good quality evidence, and these are called SHARE recommendations. And in the European recommendations, other agents like MMF may be useful, and they use it in current practice. And there is also recommendation based in open studies that IV cyclophosphamide for systemic involvement is useful, especially for those patients with skin ulcerations. And the anti-TNF that recently were added to immunosuppressive refractory JDM. The B-cell depletion by rituximab may be considered as adjunctive therapy, but you must have in mind that very small children, they are difficult and they have to monitor for hypogammaglobulinemia. And it takes more time. It takes 26 weeks to work. And for calcinosis, it's another recommendation of intensifying immunosuppression. The other problem that was on the recommendation, and it's difficult to predict, is when to stop after a period of remission. So the recommendation was stop methotrexate after the patient is at least 1 year off steroids. What's very difficult to reach. There is recommendation about starting earlier physical activity to recover the muscle strength. And about biological therapy, I have little to say, but most of the studies are open studies. There is in this systematic review of the literature, all the anti-TNFs and abatacept have been used with, in open studies. And there is another revision about new biologics in the future, and the new biologics are based mainly in the findings of interferon response and interferon signature in these patients. So I think the most important result we had for the last 10 years is that study that included also just 4 patients. This is the study that describes a compassionate study of baricitinib in non-responsive JDM. So the interferon signature correlates with disease activity, so it was tried because the similarity of the interferonopathies, especially Kendall disease. And this is the first report in JDM, and as you can see from the graphs and as you can see from the pictures, the authors describe improvement of the skin disease and also the muscle disease by those parameters of the corset measures. And you can see in the lower part of the picture the improvement of the photosensitivity rash and the V-neck in the before and after treatment. That is very clear and it's very encouraging. This is by Dr. Green, who preceded our talk. But I have to speak you about the real world. The real world is this, refractory JDM and calcinosis. And this is a patient of mine, a long journey of exploring different treatments. Early disease, she started at 3 and received all the treatment I spoke about. She received oral prednisone, methotrexate, many pulses of methylprednisolone. But in spite of that, she had ulcers. She developed calcinosis, in a very severe calcinosis. These pieces of chalk were collected by the mother in a tube every time she came to clinic. And every time she came to clinic, she had some infection in the ulceration. So we tried also intravenous immunoglobulin. We tried cyclophosphamide. And because of very low bone mineral density, we use for the treatment of calcinosis palmidronate. But unfortunately, we missed this patient with very much suffering. So we have to speak about 2 issues that I consider very important. This patient started very early, so early disease, and they have, as described by my colleagues and for these recent authors from the group of Dr. Cesar Ozen, they describe a series of young age patients, and they have indeed more severe and more diagnosis delay, and they have more relapsing rates. That is risk factors for calcinosis. For the calcinosis risk factors, Sorry, I'm going. How do I go back? I'm going ahead, go back. How do I go back? Okay, thank you. So, back to the calcinosis. That's because I put the ice age because it's really a very difficult issue to speak you about. The frequency of calcinosis in the previous series, it was very high. And you have all the types of calcinosis in this series, you must know. Very disseminated calcinosis, tumoral calcinosis, and even in our Brazilian registry, we recruited patients in the first 6 months of disease, and we have 12% of calcinosis from the beginning. So it's a difficult issue because some risk factors are recognized, like prolonged CK elevation, some polymorphism, or even some features in the phenotype, but the early age and the reticular pattern of calcinosis is the most important risk factor. So we have to keep an eye on this. And all the mechanisms that involve calcinosis, I won't extend this too much, but it's important to know the persistence of inflammation and the damage of the tissue because of the calcium deposits is the critical factor. And sometimes we try to treat this just removing the calcium, but you have to control the inflammation, and the inflammation is the key to sort calcinosis. That's the reason it's recommended, in spite of all these treatments I listed here, with many agents that act in different parts of the calcium deposits. It's important we have to optimize the treatment. So for all the agents that move calcium from the tissue, I have to stress the biphosphonates. It's that we have more experience and more practice. It's that on the literature, you have more description of resolution of deep calcinosis. They have different mechanism of action, and they have been used, especially the intravenous pamidronate, for a long time. This is an anecdote from a case series from Sao Paulo, from the Clovis group. That's a deposition and surgical removal of calcinosis from the urinary tract. This is a neurology, because sometimes the surgical removal is some form of treatment of calcinosis. So there is a list of agents, as you can see, but most of you know that in practice it works less, and even the biologic treatment in the beginning is recommended. So early treatment and recurrent episodes of inflammation are critical for the calcinosis, so you have to give an attention of this. So for a summary, to summarize what I've said, JDM has progressed, and the evidence is expanding. And of this evidence, the core set of outcome measures, the essential items for clinician definition of improvement, and even the muscle biopsy standardization were important hallmarks for the future. But the Myocytes Association towards personalized medicine is still far from our daily practice. And I think the most important issue was the type 1 interferon as a target. So the promise of an emergent trials or some other JAK inhibitors are in the future. And these trials, the chair guidelines and the cross-age studies. And last, I would like the Brazilian group. We were a very tight-bound Brazilian group who set up a registry. We had the support of the Brazilian Society of Rheumatology. So with this picture, I would greet you all dearly all the Colombian group of pediatric rheumatology. And thank you very much for your attention.